Ready?
Yes, absolutely. Yes. Go ahead, sir. Yeah. Okay.
Yeah, good morning. So this morning I'd like to present to you the study I conducted in Zambia, Africa, cannabis use and its socio-demographic correlates among adolescents in Zambia. In this presentation, I will ground the aim of the study, the methodology, the results, discussion, and conclusions. Zambia is a country in Africa which shares common borders with Angola, Republic of Congo, Tanzania, Mozambique, Zimbabwe, Botswana, and Namibia. It has about 700,000 square kilometers for a population of only 14 million. So have plenty of space, and 85% of people live off substance farming. And now many farmers are also cultivating cannabis. It's becoming a problem because its yield, it brings more money than other crops. And the government is encouraging agriculture. They want to give every youth who turns 16 50 acres of land. But then what are they going to do with that land? Many may use for cannabis cultivation. There's also a move in political arena. There's that is pushing for the liberalization of cannabis use and sale. It hasn't, but it's in the it's there out there. So it's a major problem, especially when it starts that high, as we are going to see among adolescents. So cannabis use among adolescents varies between countries and within countries in Africa. Sex are common demographic factors, and a higher proportion of boys and girls use cannabis. In other studies, we have found something different here. And also, there's a higher prevalence use among older adolescents. Cannabis dependence in adolescents predicts increased risk of using other illicit drugs, poor academic performance, and the psychotic symptoms. When we decided to conduct this study, there was no data except the one from 2 decades ago. And this is common in developing countries, especially in Africa. There are no data. As a result, it's very difficult to find the ammunitions to push for policies, and even ammunitions for those who want to do interventions, because people say those data are from America or from Europe or from elsewhere. They're not. So, I have worked with others to provide data in different countries around the world, so that those who are looking for interventions have their own data, and those who are pushing for policies has also their own data to use as they push for policies. So 2 decades ago, it was 10%. The aim of this study was to estimate the prevalence of cannabis use and its socio-demographic correlates among school adolescents in Zambia. The only study that was conducted 2 decades ago had reported a prevalence of 10%, but had not studied the correlates of cannabis use among adolescents. With the methodology, This was a secondary analysis of data from the Zambia Global School-Based Health Survey. If you are familiar with this survey, as funded by CDC and World Health Organization, they, after 2 years, they released data for researchers who want to do analysis. So that was an opportunity for us to use this data to provide the estimate of prevalence of cannabis use and also the correlates in Zambia. Global School-Based Health Survey uses a two-stage probability techniques, and the outcome variable was lifetime cannabis use. Data analysis was performed using SPSS version 14.1. A weighting factor was used in the analysis to account for cluster sampling, and the frequencies were obtained as the estimation of prevalence of the outcome variable. Proportions were compared using chi-square test at 5% significant level, and barcode logistic regression analysis was used to estimate the association between relevant predictor variable and the outcome variable, which was the use of cannabis. About ethical consideration, we analyzed de-identified data that are in the public domain with global authorization for reuse. The Ministries of Health and the Ministry of Health and the Ministry of Education in Zambia had provided ethical oversight of the Zambia Global School-Based Health Survey. In this study, informed consent was obtained from students and parents. Confidentiality was upheld through anonymity in completing the questionnaire. Results: we found that overall 37.2% of the respondents, 34.5% of males, and 39.4% of female reported having ever used cannabis. In a multivariate analysis, males were less likely to have ever used cannabis than female. This was in a discussion was contrary to previous reports, but we will say more in the discussion. Compared to 16 years or older, adolescents aged 14 years were 45% more likely to report having used. Other factors that were significantly associated with cannabis use were history of having engaged in sexual intercourse, with ratio 2.5, and alcohol use, and having been bullied. Adolescents who reported being supervised by parents during free time were less likely to have smoked. Our prevalence of 37% was higher than the 26% reported in Nigeria, and 16.9% KwaZulu-Natal in South Africa, and much higher than 6.2% reported in Zimbabwe. So we really can't find, we do not know exactly why. Some of the reasons may be the definition of the outcome variable. Our definition was lifetime use, and some studies have used use, so that may be one factor. And explanation may just be the fact that in Zambia they are really farming and there's no control. We do not know whether there are much more control in other countries, but that's a situation we found ourselves in. Our findings that girls were more likely to smoke cannabis than boys was different from previous studies. And it wasn't a surprise for me because in another study I conducted in Zambia, girls were more likely to have smoked, current smoking, than boys in adolescence compared to older generation of 30s and 40 years old. So it looks like among the new generation or adolescents, girls are smoking more tobacco and now cannabis. And part of it is the way the companies are promoting smoking in developing countries. As you know, they have moved from developed countries to developing countries and pushing. And one way they push among women and girls is like equality, and because in Africa only males smoked. Now the companies say no, why only males? It's like also push for equality, and then that misuse of that slogan is getting more into the head of younger adolescents. So it becomes a big problem. So it appeared that it had become fashion for girls to smoke, thus surpassing the prevalence for boys. Our findings that respondents aged 14 years or younger were more likely to have smoked cannabis than 16 years or older is different from previous studies, but once again, wasn't much surprise for me because now they're starting much younger. In another study I conducted in the Democratic Republic of Congo, found that younger adolescent or even pre-adolescent had a higher prevalence of smoking than older adolescents. So unfortunately, they are younger, much younger. The fact that those who reported cannabis use were also more likely to have used alcohol and engaged in sexual activity confirm the clustering of harmful lifestyles. So the of harmful lifestyles is not new. It has been published earlier. The association between cannabis use and bullying victimization raises an important questions, important issues, and it has already been reported. But why is it so? Are they using cannabis to cope with bullying, victimization, or is there once again because they are using in harmful lifestyle, other harmful practices like fighting, or we do not know, but it's an important issue to explore further. In a large study of 8,000 middle and higher school students in the United States, roughly observed the link between involvement in bullying and substance abuse. The fact that adolescents who were supervised during their free time were less likely to use cannabis underscores the relationship between supervision and risk behavior among adolescents. Oh, this is no surprise. Previous study and my other studies have found that parental supervision was associated with this exposure to other risks such as injury and fighting and alcohol, tobacco use. So it's a very important protective factor. So the limitation of the study. This was self-report to the extent that the respondents were not truthful, that may have impacted the results. There were no biomarker studies to verify whether those who said they were using cannabis were reusing, or those who said they were not. And also about 25% of the questionnaire of the respondent or the people were solicited to participate in the study did not respond to the questionnaire. Respondent did not, about 25% of the respondents, should make the question, 25% of the respondents did not respond to this question. So we do not know what are the characteristics of those who did not respond, those who have responded. Were they, and to the extent we do not know the characteristic, the difference between the characteristics of those who have responded, those who have not responded, then there may be some bias. In this study of Zambian school adolescents, we found a lifetime prevalence cannabis use of 37.2%. Parental were associated with lower likelihood of reporting cannabis use. This study confirms observation from other studies of the clustering of harmful lifestyles among adolescents. Interventions aimed at promoting health among adolescents may benefit from taking these findings into consideration. So I'm glad to answer any question that you may have.
Okay. Someone.
Yes, ma'am.
When you compare your results to other studies that were done in Africa, do you have any information? Do you have any information on how these prevalences were calculated for South Africa, Zimbabwe, and what was it, Nigeria?
Yes, I do. Some were. That's what I said. Some were current use, while others were ever use. So it was not the same. The common definition. This paper was published. I have details. But I have it here. Some were ever used cannabis, and the others were current use, like within 30 days, which may account for the difference in prevalence.
Okay, the reason why I'm asking, I cannot speak for the rest of Africa,
Yes.
but in South Africa it is against the law to use cannabis.
Okay.
And I'm just wondering specifically for the South African prevalence, how accurate that is.
Yes, that is a good point, because even in Zambia, that you can tell people this is anonymous and this is, but to the extent they believe you or not believe you, It's so that it's really the point you are making. It's well taken. This is underestimate because if you and they're reporting they may be afraid. Even the 25% who did not respond, maybe they were using it. They said they want to get in trouble, or whatever. Yes, a very good point. Thank you. Yes, sir.
Yeah. Is it legal in Zambia to smoke cannabis?
No, it's not. However, it's not very much enforced, but it's illegal. It's illegal, but the enforcement part, that's where the problem is. And also, it's the population is scattered. It's a really large country compared to the population of 14 million and 700,000 square kilometers. In Zambia, if you go there, we find here, and then you have to drive maybe 20 miles. We find another village. If they are doing it in their village, even though it's against the law, to the extent what difference it makes, it's on the book. It's illegal to use it, but people use it nonetheless. But there's one political party is pushing to make it to use and to sell. They're saying people are using it anyway, and we're not getting any tax for the business. So, but it hasn't that law yet.
And what is the reason of women are more than the men's using cannabis? What is the reason you think?
The reason?
Women's, the female.
Oh, yeah. Yes. Really, I cannot speak. It's just I do this epidemiologic studies in different countries for the reason I've mentioned before, to provide data to those who want to do intervention, who want to push for. But in developing countries, it's a trend that women or female young girls are picking up compared to maybe the generation of their parents. And the reason is that the tobacco industry is just pushing and using, say that equality, and we need to be able to do everything that males do, and then that's of the when it comes to cigarettes, for example, that I'm free, I should be able to smoke in the public, to do this. And when we look at the data, that when we do these studies around the world, that the preference for women who smoke has gone more earlier than before. I think that the tobacco industry has something to do with it. Yes, sir.
With respect to with the last question, I would like to know if you analyzed any relation between girls addiction more than boys, and its relation with early pregnancy, early age pregnancy, abortion. Have you analyzed this?
No,
item?
but that would be a good thing to do. That would be a good important to do. But we did not. As a matter of fact, they don't have the information, but that's very, very important. Yeah. Thank you.
Yes, please. Is it more complicated than it appears? Kids could have so easy the cannabis to smoke. This is the point.
Excuse me, say it again, please.
How can these kids could easily have these cannabis available to smoke?
Oh, okay. That's it's locally produced, as I said. It's locally produced, as it's available, and also it's a lack of education because, for example, I have found in some country in Africa where women this was at one clinic, and I said it was woman, what that you are giving to your baby, and she said it's milk, but it wasn't milk. When I inquired further, it was alcohol, and but she called milk, and they said, why do you alcohol to your baby? He said, it's medicine, because it's medicine for the pain, So because when a baby is pain and crying, when they give a little bit of it, they sleep, and she sleeps. So that is just a lack of education, and this cannabis is available in the village. It's a grandpa or father is smoking it, and the children just also do it. And sometimes I've seen, for example, the parents that ask the children to go to put, so when they put the pipe and of tobacco, they say, okay, go and put fire on it to light it for me. So they go and just they get used to it. It's local produced, locally used. Unfortunately, yeah. Yes, ma'am.
So I can hear you.
Do you plan to show these results to the health authorities who oversight the study previously and said that they didn't have?
Oh yes, of course, yeah. Because I work with national researchers in Africa and other countries, helping them, and this was published, and also was shown at the Ministry of Health. And one of my co-author also works with World Health Organization office in Zambia, and also with the ministry. Yes, it was submitted. It was presented to the Ministry of Health, and also to office in Zambia, and also advocate for health are using this push for policies and also for interventions.
Any more questions? Thank you very much.
Thank you.
It's not, all the slices are not as well as I thought to. But as you know, my name is Joost Rijsma. I'm from the Netherlands, and I'm from Nijmegen, a little village at the eastern part of the Netherlands. And the Snowbine Bridge, the bridges of the movie A Bridge Too Far. Maybe you know that movie of the Second World War, and that's one of the bridges of that movie. And you know, the Netherlands is known by tulips. So I thought maybe in this time of year, the tulips are more or less gone now, but they are still. And a little village near Nijmegen is called, and that's called San Antonio. So I live nearby San Antonio, far away. I will present this story also on behalf of a colleague of mine, Esther Kolen, a general pediatrician. And we started in the early 19s in the Netherlands with APLS courses. And I will tell you something about the studies we have done about those courses. And we went on to simulation training in the early 2000s because we wanted to train teams and not individuals. So we went on from individual training to team training. So, and about the studies we have done about this training program. So I will start with advanced pediatric life support courses, and then why should we need simulation training as an educational tool? What is the advanced tool helps us in training people for emergency medicine? And what are the prerequisites for training programs? And then we have looked about leadership. Is there any leadership in pediatrics? Are pediatricians, are they leaders? Changing their leadership style during their residence. And I'll show you some results of that study we've done. And the last studies we have done are about situational awareness. And I will tell you some early results of those studies. And then we are looking how to go further, and I will share with you our future program, training programs. When we started in the 90s with advanced pediatric life support, what are we going to train the people? And more or less there are two types of advanced life support courses. There are courses also which consider only the primary assessment and survey and resuscitation programs, like the Pediatric Advanced Life Support course of the United States and European Pediatric Life Support course. That's only the first two. And then you have the Pediatric Life Support courses also in the United States and also in Europe, that comes from Manchester. And they also train people in the secondary assessment and sometimes in emergency treatment. But it depends on the kind of training program, which kind of aspects are especially supervised. There are no in those programs. That are not those programs for. So there are different kind of programs. You can also think about the neonatal life support courses. Essentially on the first two, primary assessment and resuscitation. And what is the effect of those courses? And we did these studies in the 90s. I've used the Pediatrics levels of training, of learning for that. And level 1 is only reaction. How is reaction? It feels good, I've trained, it feels good, and I've learned something. But what? We don't know. The second level is you have learned something, and how can we look for that? However, we want to get behavioral change. You should behave yourself in another way after a training program than you did before. And essentially, when a training program has changed you and has changed the team, the situation around that team should change also. So there should be organizational performance and differences. And we have done this for the APLS study and self-efficacy. In the first place, self-efficacy is only level 1. How do you feel? And self-efficacy is one's belief in performing an action in the future in the right way and to get the goals wanted. When you have an APLS course, you have self-efficacy, your own belief in performing a task in the future. So this is a good thing. the APLS courses. This study was done by going to hospitals, a simulation in a room, and going to a doctor and tell, come, I want to, let's show what you can do at this moment. And we ask them before, can you do this, what is your self-efficacy, and thereafter, let's show. And as you see, the self-efficacy is for people having done the APLS course is higher than for pediatricians not having done so. And it's for resuscitation global, but also for cardiac back and mask. It's not that great a difference, but there's a and especially insertion of an IO device, an intraosseous device. Then we have scores. What they show to us. We have a mannequin, and we have videoed that mannequin, and they had to resuscitate that mannequin. And what you see is that people are doing better when they have done the course. However, what's very strange, the time to start chest compression is much longer, less course, than when you didn't have done the course, because you made first the E, B, C before going to chest massage. So, and that's very important to start chest. So that's a little bit of problem of those. So you have to check something, and thereafter you start, and you do it, but that leads. Thereafter we saw we can train individuals, but how are they working on the floor? They are not working as an individual, they are working in teams. So we have to train the teams in the hospital itself, not in the nation, not on courses elsewhere, but in the hospital. So we have set a simulation center in the early 2000s, and we have given many training programs there. So that we have done, we thought members of pediatric teams are expected to have the same goal. Yes, also called a shared mental model. But is that true? Have they the same goal? And we know, although members are sufficiently trained individually, team work skills are different from individual skills. And that you can see in the CanMed criteria. And you should learn to work as a team and not as an individual. So we started in the early 2000s with high fidelity medical simulation. And Eisenberg has done a study about it and published it in 2000 and showed what are the good things about high fidelity medical simulation. You take it on video, so you see yourself working afterward, and you see your communication with the other people of the team. And you can't, from that you can get feedback. You can provide feedback. You can provide feedback yourself, because you see yourself and nobody has to tell to you, you see what you've done. You can do it repetitively. It can be done over and over and over again. You can integrate in a curriculum, and we have done that, as I will show you in one of the next slides. You can train different clinical conditions. You can train clinical, technical conditions and non-technical conditions, like you want to do at this moment. You do it in a controlled environment, because the patient won't die. We never let a patient die, and change then the clinical course so people can handle that course. It's not our task to make them to get them into danger. It's to learn from the patients they are taking off. And we know the simulator has some validity. We have a physiological simulator, child simulator, and it has some physiological validity. However, it is very expensive to start with a simulation center, and to get it going, it is very expensive. So you have to know it has an additional value. And, and we asked ourselves, has it that additional value to get the simulation center? So we have done some studies. One of the things we thought of was when we are training people and we are looking at the effects, everybody of those people has a different background and different years of experience. So how can we study the effect of our training program in so diverse group? So we have started with students, and that are fifth-year medicine students. It is almost being a doctor in the Netherlands. And we have given 3 kind of training programs in emergency. A problem-based learning program, that's not doing something with hand, but only doing it by paper and resolving problems in paper. Then we have done it in European Pediatric Life Support course-like, and in that course, the scenarios are very short, about 15 minutes, with feedback. However, the feedback is not video taken. So the people, the student has done the simulation, and thereafter you are going to tell with the other students what did he well, what did he wrong, and how should he perform in the future. But he doesn't see what he's done. So he should remember it, what did I do, and is that true what they say to me. And another group we trained with high fidelity simulation training. And what you see that in all groups, we had 3 simulations, and in all groups, the students became better after the simulations. However, the students doing the high fidelity simulation training and seeing themselves are doing much more better than the students they have not done. So when you have a similar start point, people become faster, better than in another way. So it seems you can train people in a better way with video-assisted real-time simulation program. Thereafter, we have looked at human factor competencies. We know more and more that human errors are due not to technical failure most of the time, but about human factor competencies. And maybe one of that is the technique, to understand the technique you use, to the technique, but it can also be the organization which can fail, and the environment. And maybe you are not tasked, your education is not good enough for the task you have to perform at that time. So we have looked at human factor. And this is our training program for all the people of the medium care, pediatric medium care. That's all the nurses, all the residents, and all the staff are coming together and training together as they do on the floor. And we started in the morning with ABC. What's ABC? Again, we repeat it and repeat and repeat it every time. Thereafter, we give them about resuscitation, child. And then we started to introduce the simulator program to tell something about crew resource management. What does that mean? How can you speak to each other? How can you help each other? And in the Netherlands, we have several what we call VMS programs to look at the different hospitals and how they are doing. And one of the VMS programs is recognition and treatment of the critical ill patient. With that we start. And then we go on to recognition and treatment of pain, recognition and treatment of sepsis. And depending on the group, we do high-risk medication and medication verification. But that belongs to the group. That's our program. And we do it in simulation style. So every time we have a simulation, we look after the simulation with video, come with feedback, positive feedback or critical feedback, and thereafter we have a workshop about what does it mean? What does mean recognition and treatment of critical illness? So we go on the circle once a year for everybody. So that means that we have 40 training days a year. Just every week almost we have a training day. And we have here 4 people in one scenario. So we have, you can see we have 3 scenarios, so we have 12 people doing a 1-day training program. We have looked at the prerequisites. When you have a training, you want a training to be realistic, so the people can recognize themselves what they are doing on the work floor. So we ask them before and after what's the most important of the simulation. And most of them tell the scenario content is very important. So it should be a realistic scenario, not a scenario of all problems that can happen in the child, but it should be realistic. They should recognize the problem. And the real-time performance, in EPLS courses, it is not real-time. You say, I put in an IV and an IV is in, and the fluid is going in. No, in a scenario, in high fidelity, the IV access costs about a minute, or when you do it in IO, intraosseous, it costs 30 seconds. So it depends on the way you do the time taken. And fluid costs about 5 to 10 minutes before it is going in. And one of the strong amounts is also the monitor of the file. This kid has viral parameters. It's also breathing. When you get a hand before his mouth, CO2 is coming out, and you feel CO2 is coming out, and it's breathing. What's less important is the simulation. When you start, the first 3 minutes, and thereafter, everything is forgotten. You are real thinking. So the physical appearance is not that important anymore. Start, yeah, but after some minutes it's gone. And communication with the mannequin, we do. The mannequin is talking to the nurses and the doctors. That's not that important. But we saw that the perspective is strongly on the setting and the learning objectives and the learning goals. When you have technical objectives, it's not that important when you have non-technical aspects. There's communication, working as a group, etc. And what we saw was during a simulation team training, that the team assembly and role playing can become more important to participants, while physical aspects become less important. So a nurse should be doing what she's doing on the floor, and not taking the position of the doctor taking the position of the nurse. So one should play each other's own role as on the work floor. And how we looked also at prerequisites, and we looked at self-efficacy of the people, and what we saw was that older people get more self-efficacy, more and higher self-efficacy after the training program than before, and the state, as you can see here. And that was also true for neonatal intensive care nurses, which we had the same training program. Thereafter, we have looked at leadership skills, because more and more is shown that in those kind of training programs, the technical skills are well trained, but not leadership roles. And so we have looked at leadership. We have leadership roles. We have only looked for it. And you have more or less, you have 4 different types of leadership in an immersion situation. You can have at the side, you have the directive type of leadership, and in the vertical, the supportive type. So when you have directive and non-supportive, you are delegating. So you can search to each kind of leadership in this program. And what we have shown was that pediatric residents in our country are always coaching, as you see, and they are not changing their way of leadership during their training program. So 5th year, and even when you are ready as a pediatrician and you are a consultant, you do it in the same way. So we choose, we choose people for the training program who are people who like to coach. We think we don't train them to be coaching people. We think we choose them to get in the training program to do so. Because we don't see any change, any chance the training program. And it depends on the scenario and the phase in the scenario that the directing leadership role is the next important role for pediatricians. When you look at this study has also been done by internships for surgical residents, and surgical residents are more directing and delegating. So we are different kind of people, I think. After we started to look at situational awareness, so we have learned how to kill deer, but we should look at the back, and maybe we will be killed by another predator. Well, as you see, it's a lion, a tiger in the background who will get you. So you have to have eye for the situation around you. And we have done this with this program. And what you see is, let's start looking at this. You have 3 different kinds of situational awareness. The first one is perception of the situation at that moment. What is going on now? The second one is to understand what is going on now. And the third one is what is going on in the future. What leads this situation to, and what should I adapt for the future? And that depends on your experience on forehand. What are the nurses you are with you training? It depends on the patient, etc. The hospital you are working in, and you will then perform an action and get feedback. And this is what we have looked for. And what we have trained for the last few years is not to do well in the situation, but predicting the situation, and look if it's better for the patients in that way. So we started in the hospital with a hospital change. We started with a system we call PRESS, and it includes PEWS, the Pediatric Early Warning System. It includes high-risk therapy, familially expressed concern, communication breakdown, and gut feeling not expressed as the watcher. So we can give each patient a color, red, orange, or green, depending on the PEWS and the other ones. And so we will, on forehand, look at a different way to children. We have published that in the European Journal of Pediatrics, and we think it's working. And one of the things was also that we have learned the people to get the message from one to each other in the same way. And we used SBAR for that. There are more systems, but the SBAR is one of the systems. And you have to tell about the situation, about the background, assessment, and the assessment. You use the ABC. Then what is the recommendation, or what do you request? So this is a standard way of communication with each other. And how did we do that in our training program? We called the SAGET type of study, and we did it with a simulation. So a simulation program is running, and at a randomly select moment, we froze the simulation, and all professionals were asked their perception of the situation at that moment. The scenario setting was in general a subacute deteriorating clinical patient. We stopped for 3 minutes. The monitor was blanked at that moment, and all professionals were asked to fill in a multiple choice question about their current perception of the situation, including perception. What's the pulse rate, what was the respiratory rate at that moment, what do you think the problem is, and how do you think you are working as a team at that moment. And we used those papers for the debriefing. We tell at the debriefing, we are now seeing this, and you have filled in, you didn't understand what is going on now. But can you look at the video and say what is you didn't know what is going on at this moment? Why didn't you ask what is going on? What do you think? Doctor, what do you think is going on now? What should we do? And you should talk to each other about the simulation is going on. And our experience with this kind of program for situational awareness is that the disturbance is minimal. And we even found out that the timeout can increase individual situational awareness. They can think for a moment without doing. They understand the situation better. However, complementary situational awareness of nurses, when they are going to start thinking and putting it into the simulation, can be not that good. So there are two kinds of problem. And what we also find out that the perception of leadership differs between nurses and physicians. When you place in the scenario, when you have hands-on and saying something about your thoughts, that is the leader for the nurses. But the leader for the physician, for the residents, staying by the patient, may be the person who's getting at the back and thinking about what's going on and what should we do. That is the two things. There's quite a difference about thought, who's the leader in the team. And we asked for a mark for teamwork at everybody. And we thought, and that's especially for nurses, that the mark for teamwork is mainly given as a consequence of the perception of importance of everybody's own task. So when a nurse is back mask, ventilating, and nothing doing else, and the leader has not said, you are doing quite well, it's going well, so keep on. When the leader doesn't tell that to her, she thinks, I've done nothing. So what I'm doing here? So it's very dependent on the interaction, how it feels as teamwork. So we think that for effective teamwork, explicitly improve speak up. How we tell the people, speak up. Let's know your meaning. We have thought of that leadership may be possibly of two tasks, the hands-on leader, management leader, and the hands-off, the overview leader. And for nurses, those people differs, not for the physicians. So we also thought that not only the allocation of tasks, but also the evaluation and corrections during the emergency program itself. And what we think is also important, very important, when you are in doubt when you're being a leader, share your alternatives with the team and share them and think with the team what will we going to do. So we think changes for our future training program are measuring situational awareness not during simulation but also in real clinical practice, and more and more training interprofessional working. So doing with the gynecologists, the emergency physicians, the pediatric surgeons, and not pediatrics and the nurses, but also with other professionals. And which is the problem in the Netherlands, that we have so many safety programs. And every program wishes to be important and to get time from the professionals. So how can we go on with this program and sharing it with other programs and government obligations. So time and money are the major problems we have to go on with this problem. So thank you very much for your attention. We think keep calm, teamwork makes the dream work. Thank you very much.
Any questions? Yes.
around this item in education for physicians and nurses. And I would like to know if you offer manuals or some papers before the
For the training.
training. Yeah.
Yeah. No, not manuals, but e-learning on the computer with e-assessment. So we do everything on the computer before the real training program.
But you do you evaluate or test if participants has basic knowledge of?
Yeah. Everybody once a year have a pediatric basic life support program. Everybody, each year, and everybody has done what we call a training program of vital recognitions of vital signs, and start the immediate actions. So every nurse and doctor has it, and all doctors has done the APLS course, the Advanced Pediatric Life Support course, and the Neonatal Support course. So they have had their individual training programs. Everybody.
Okay. The last question is if you offer certification, annual certification as a for stimulate the people.
Yeah, we get everybody has to get some certificates in the Netherlands, certificate points, also nurses, and we have done this with this training. So everybody gets their points after a day of training.
Okay,
and that's 8 points in the Netherlands.
Anybody else?
Okay.
Do you offer this in other countries, this training?
Not our simulation, because we have a high fidelity mannequin, and we can't transport that mannequin. But yes, the European Pediatric Life Support course I give in Germany, in south part of Germany. I'm course director there, and we give it in the Netherlands, in Belgium. I've given it in Italy and Spain. Yes, we do. But not that's for the individual professionals. The team training is, it's very difficult to give it with a high fidelity, because for the high fidelity you have a large computer you have to get with you. They are in vans, large vans, but we don't have them in the Netherlands. We have some centers we train them in. Any more questions?
What would you recommend how often a team should go on a training? Because as we all know, we forget things, and I think it won't last like years.
Yeah, it's a very difficult question, because when you look at the technical aspects, you forget things in 3 months when never have done in between. We do this because of the time-consuming training a year. And we think you should give it, and every need to give it twice at least, but it's very expensive. It's too expensive, because you have 14 people away of the work floor a day, 40 days a year. That's too expensive. Yes, you can. Yeah. Yeah. Okay. The residents in the Netherlands have to do during their training program the neonatal advanced life support course from now on. That's 2-day course for neonatal resuscitation, and they have to get their advanced pediatric life support in the first year of their training. So every residence, and it is paid for. So they don't have to pay it themselves. The organization have to pay the residents. for that training program. But it's in the Netherlands, it's not locally. Everybody has locally training programs, and the most have what we call just-in-time training. So there is a little moment of free time. You get a mannequin and you train. We do that on the in neonatal intensive care unit. We have an high-fidelity training mannequin on our neonatal intensive care. So before going to a difficult child, for example, a child with an hernia diaphragmatica who should be primarily intubated, we train that before going to the birth of that child. We're training it on the mannequin with that team, and then the team is going there. Whenever possible, it's not always possible, whenever possible, we train it in that way. So everybody has its own choice how to train in their own hospital. And there are no nationwide team training programs, only the individual programs like NLS, PULSE, EPLS, and that kind of programs. No questions left?
I think one.
Yeah? Okay.
It's exactly 10:40.
We can go to the break.
There's cookies and coffee outside.
And thereafter we have still two patients left, I believe.
Well, actually, let's see, there's, we're moving, Freddie, we're moving you first in your, what would have been your two, there's 3 presentations left.
Okay.
After break.
Fine. Yeah?
And then we go to lunch.
Okay.
No. So, during those presentations, it'll be like it's been, these ran a little longer because people were not here, but in the next presentations, we'll try to adhere to the 20-minute situation like we did.
And then we'll stop in time.
All right.
Thank you very much. Have a good break.
So, 5-minute break. Thank you.
procedures.
Okay.
Thank you.
Thank you. Thank you for your invitation. I'm trying to speak very slowly. It's not my better languages. So this is focusing on a special population of children that need gastrointestinal endoscopic procedure. This conference is dedicated to those children that got troubles in these procedures. I have no declared conflict of interest for this conference. I have not received funds. So if anyone sees a conflict of interest, please tell me. Okay. Gastrointestinal endoscopic procedures in children are focusing diagnostic and sometimes, so few times, therapeutic invasive procedures, trying to deal with fast track analysis in those children. Okay, these children remains short in recovery area for these procedures and then return home or your room. For this target, we focus in three main problems or items. How to deal with unconsciousness of a patient, how to deal with immobility, because risk of damage with movement, and very important question about autonomous protection, because almost all problems has to be related with reflex, autonomous reflex of airway and cardiac reflex. This is a picture of my service. This is my chairman service, and we always are present in all procedures making in children's. We have few options for guarantee these three objectives in children, and minimal sedation or moderate sedation are not options for this child because obviously reasons. Yeah. If we analyze deep sedation, analgesia, and general anesthesia are not, or they are similar in the target, and it's not easy to state whether you are or in deep or general anesthesia. Okay, so represent a potential risk situation because probably pulmonary function assist intervention or cardiac assist may be required. Okay, and but in expert hands or skilled hands, these procedures are doing in an easy way. Okay, we have two options for this for deep sedation or general anesthesia, but for the first case we always need an IV access like this in these children, but again children cries when we use IV access previous to the procedure. So we have opted for inhalational anesthesia in this patient, and in most of the procedures we not use an IV access for these procedures in the most part of our children, especially for ambulatory procedures. Okay, the general anesthesia offers an easy starting and autonomic control better than deep sedation, but contrast as is postoperative agitation related with the use of inhalational anesthetics. That is a frequent problem in children that is not infrequent in when we use common drugs for sedation as propofol, but dose of propofol led us to induce more deeper states in these patients. So we opt in our institution for general anesthesia more than deep sedation. And sedation or inadequate sedation is related to bad outcomes and troubles in the children, especially because people tend to think that deep sedation has been to be easy. Yeah, that is not true. We think complication in children under GIP is a reality, even in skilled hands, with a 1.3% of cases when general anesthesia is done. Even less than sedation, and is related to inadequate pre-procedure assessment, mainly inadequate monitoring and assist during the procedure, and related with a deficient training in the personnel too. So there are many places in the world when sedation is administered by the same person that do the endoscopy. That is a very risk problem, health problem, especially for those centers, private centers, that think that one more person in the procedure is related with more cost. But the truth is that one only complication is cost more, is a more very much cost that the cost for a person, frequent person. Those we have analyzed this situation. Sedation is administered by a non-anesthesiologist or a nurse, anesthesiology nurse, and we have found the incidence of adverse events is unfortunately high, and failure to achieve these goals of sedation and analgesia remains in the order of 12 and 28 of when we assess by consciousness monitoring, because we are able to measure the unconsciousness by spectral index monitoring, as I am going to comment follow. Agitation and respiratory events are frequently in when sedation are administered by non-anesthesiologists, and we ask the children will go to next procedure. We got a negative because of explicit recall of a bad experience in these children. Again, we're gonna cry. So the Joint Commission, almost 10 years ago, have defined the basic safety condition for endoscopic procedures in children, and he has and they has established that children under schedule to gastrointestinal endoscopic procedures may remain with a pre-anesthetic assist, pre-procedure assessment, and basic monitoring. But I'm going to specifically to capnography and consciousness measuring. Okay, capnography as a relevant monitoring for detecting respiratory problems, even before saturation shows any information. And this is very important to every places where GIP procedures in children have done that has a capnography. And we're not sure if consciousness monitoring by these devices, special devices, are necessary for those more than one person care for saving this patient. The main question is that we need a person dedicated solely to monitoring and safety, different to the endoscopist in children. We use this fashion mask with a special port for the endoscopy, other port for ventilation, and in a few percentage of children we need an endotracheal tube because the systemic state of a kid or some special considerations for the procedure. Okay, so we make an analysis of 2,200 patients underwent endoscopic procedures between 2010 and 2014. We found that the most important severe adverse events were respiratory ones, and leading by hypoxemia and obstruction events as laryngospasm and bronchospasm. And when these children remains in this condition, it appears bradycardia and cardiac compromise. So the main and important question is the majority of severe adverse events in these procedures are respiratory. When we analyzed non-serious events, well, we found a low percentage of these events, leading by vomiting and nausea, and a few percentage we never expected this percentage of post-anesthetic agitation. We was thinking that it was more, but we was surprised for this. Okay, when we analyze demographics and risk of adverse events in this population, we found that those children with ASA status, that is a systemic classification of general status of the patient. This is related to chronic diseases, okay, was associated with a high percentage of intra-procedural adverse events, 6 times more, and post-procedures adverse events 12 times more. And we found that emergency and patients who underwent these procedures were in risk of present these complications. The gastrointestinal procedures more associated with these events, with this situation, was esophageal dilations and percutaneous gastrostomies. These procedures are related with children with systemic diseases as cirrhosis, biliary atresia, and are more diseased, more sicker. When we analyze the preoperative comorbidities and risk of these events, we found that cardiac and gastrointestinal antecedents or comorbid condition before was correlated with these events, and number of affected systems, 2 or more of affected systems was associated with a high percentage of this situation. But when we built a logistical regression for all those variables that remain significant in a first approach, we found 4 factors that correlate very well with these procedures. One of the first is the age less than 1 year, that correlate with 3.6 times the risk of these procedures. In these children, we think these children have not to go to these procedures if not completely necessary. Okay, we expect the child grow up, okay, to make the procedure. And other situation that we know, we have known commonly, is recent upper respiratory tract infection. We analyzed this situation and we found that those children that has upper respiratory tract infection in the week prior to the procedure has almost 5 times the risk for present these events. Okay, when we compare with children with more weeks of the upper respiratory tract infection. The third place is the variable composed by low weight for age children, that is correlated with systemic combination or compromise in these children. We found that mass ventilation, only mass ventilation, functioned as a protection protection factor, because those children has a minimal invasive approach to the airway. Okay, so those are our 4 factors that include in this logistic risk model, okay, for adverse risk, adverse events in these children. Age are correlated with difficult airway management in these children. We know that those structures in this ages are in development, with a big tongue marker, and hyperreactive reflex responses in these children are more frequently because parasympathetic activation that increases the risk of laryngospasm, bronchospasm, and cardiac arrest in these children. For the diameter of a thicker diameter of airway, those patients are more prone to mechanical collapse, including the mechanical effect produced by the endoscopy. Okay, and these children have a residual functional capacity reduced and high metabolic demand. All these factors are correlated with few time to correct the situation. Okay, so this is the reason. Those are the reasons why those children are in a high proportion of adverse events and a high proportion of bad outcomes or with unplanned hospitals or requirement of intensive care unit post-procedure. Okay, those differences, low sizes of structures, convert these patients in all a challenge for the people or including the anesthesiologists who drive the airway. Okay, the upper respiratory tract infections impose 5 times of risk for adverse events if upper respiratory tract infection occurs last week prior. We have shown it. Many papers has talked about epithelial disruption even 2 weeks later. Symptoms have released, but hypersensibility of cholinergic receptors remains until 8 weeks. 8 weeks after symptoms relapse. So it's an important question to take into account. Okay, though in other surgical population, those children are related with the saturation and more adverse events. Okay, low weight and bad outcomes related with malnutrition, and we think this is a surrogate of systemic compromise for those children with established poor tolerance to stress, weakness of airway structures that impose a really challenge to the anesthesiologist. So we think that airway management in this child must be as simple as we can. Okay, the simple is no more and reserved only for those children that really needed an endotracheal tube. Okay, because for this reason we think it's very important to offer a pre-procedure assessment in 2 times, in the pre-anesthetic consult and immediately before the procedure. Okay, last conclusion, we can say that GEP for children need a care provider dedicated solely to safe. In this patient, it appears that general anesthesia offers some advantages over deep sedation for many children, and we found that 3 risk factors: age less than 1 year, upper respiratory tract infection in the week prior to the procedure, and low weight for age, function, and markers of bad outcomes in the children. And we propose a minimally invasive approach to airway. This is our institution. This is our beautiful city. You are invited to, and this is our passion, the salsa. So thank you very much for your attention. Do you have questions?
Are there any questions?
I don't know if I understood correctly. In the slide, I think it's about number 3, when there are 2 columns, the differences between the general anesthesia and deep sedation and the procedures. There it is.
Yes.
I was surprised about in general anesthesia, IV access, not necessarily.
Yeah, it's not necessary all times, because many children are in good general state for the procedure, and the endoscopy is under diagnostic approach for symptoms.
Yes. Okay.
Yeah. So we assess these children. We offer them inhalational anesthesia. They don't want to be punctured. Yeah. So we start with inhalation. We verify the potential of an IV access if it is easy. Yeah. Our nurse, our assistant verify, and as the procedure is short, maybe 5 minutes of procedures, we have observed that we don't use that IV access for nothing. But this is a question of a safe question. Okay, this is don't try at home. Okay, this is a practice in our institution. I think that every you need to know your statisticians and who are you working, okay? Who are your complications, and you decide what you use. Yeah, okay. But
Yes.
It's true. It's not necessary every time for those procedures, because all drugs for sedation and analgesia are administered by inhalational approach.
And this is this is assessed for all ages.
Sorry?
This approach is for all ages, for all the
Not necessary. Observe that children more than 10 years.
No, let's say
the
it's not about accepting or
Yeah,
not
yeah.
accepting. I'm talking about like perhaps a baby less than 1 year old going under general anesthesia. If you also assess not putting an IV access.
No. You have to assess the risk. If you are in front of a patient of a high risk, an IV access is negotiable. Yeah. So it's a very good point. I think it deserves
Okay. Well, thank you very much.
discussion.
Thank you.
Thank you for your talk. What about deep sedation? Here in my center, we use, beside propofol, midazolam, and transcutaneous fentanyl patch. You got any experience with these drugs?
Yep. Many papers have been analyzed this point, and they considered that combination of midazolam, besides propofol, is associated with more complications in this population, in children specifically. We think that propofol offers a global state that is directed to protection than midazolam fentanyl association. So we don't use midazolam fentanyl anymore for children. Okay.
There are more questions, are they? Thank you very much.
Thank you.
We'll continue with Tamar Risk who will talk about toxin in pediatric staph.
Right hip in the spica cast, as you can see here in her pelvic X-ray. So they performed, the orthopedic surgeon, the revision surgery twice for redislocation with acetoblasty and femoral osteotomy. And through this course, she had a fracture in the distal femur, and the total casting period was around 7 months. So she passed by a significant decrease in the range of motion in both hips, and she was walking with a significant limp and hyperlordosis. Her range of motion was, hip flexion was about 40 to 90 degrees, abduction and adduction and rotation were only less than 20 degrees each. Extensive physiotherapy was not beneficial and didn't show a significant improvement, so she was admitted for extensive rehabilitation, and botulinum toxin injection in quadriceps, hip adductors, and sartorius muscle, 100 international unit in each, was given. She showed marked improvement after injection regarding her range of motion, spasms, and pain. And after 2 weeks of injection, this continued the effect of Botox till the last follow-up. The second case was a 4-year-old girl diagnosed at the age of 1 year and 4 months, and she underwent the surgery at 2 years with Pemberton acetoblasty. She passed again with 2 revision surgeries in the total casting period of around 24 weeks. And with the removal of her last cast, both hips were manipulated under anesthesia, and the patient was referred for extensive physiotherapy. And again, you can see here in her post-operative pelvic X-ray with both hips after bilateral open reduction and acetoblasty. Still, she showed very limited range of motion at the right hip flexion, 30 to 90, the left hip was 10 to 90, and very limited rotation and abduction. At 3 months, she was reassessed for hip range of motion. She only gained 110 degrees of abduction and rotation, which is really very minimal range of motion. After botulinum toxin injection, more or less the same doses as the previous case, She showed decreased stiffness in both hips, and this facilitated the job of the physiotherapist a lot, and the rehabilitation measures improved her range of motion to near normal. And the last follow-up was at the age of 4 years, and she was walking more. The third case, a little bit delayed intervention because of familial issues. They refused intervention, so she was presented at the age of 7. At 5 years, the parent agreed for the surgical treatment, open reduction acetoplasty and shortening osteotomy at the femoral level. And 3 months post-operative, hip spica was removed. It's found to have fixed flexion in her left abduction and external rotation deformity. Started to walk again with limp and lordotic gait. PT as usual as the inpatient setting and followed by outpatient settings, but she didn't gain a significant range of motion. So surgical hip flexors, but also optimum results were not achieved. After botulinum toxin and extensive physiotherapy, improvement in her range of motion, decreasing her limb, pelvic obliquity, and spinal deviation as well. She showed a little bit of limitation of flexion and extension, around 10 to 15 degrees at her left hip in the last follow-up, but comparing to her previous setting, she showed much improvement. Our last case is a known case with spastic diplegic CP, 17-year-old female, presented with right hip pain and limping. She was seen as a case of spasticity in the movement disorder clinic with leg discrepancy and pain in the right hip. Diagnosed to have right hip severe subluxation, and she underwent Chiari osteotomy. But she developed severe muscle spasm post-op with pain and spasticity more on the right side. Again, we give her 100 units in the quadriceps, 100 in the adductors, and 100 in the hamstrings. Improved her spasticity, pain, and her lordotic gait. And in the last follow-up, she was using just a cane to assist her in long-distance walking. But she was pain-free and equal hip rate. So if we can take a look at the modified Ashworth scale for all patients, as you can see here, the pain scale before injection was ranging between 8 and 9, which drops to 1 to 2 after injection. And the modified Ashworth scale is ranging from 3 to 4 in most of the range of motion, and drop down either to normal or maximum of 1. So our result, that all patients benefited from the botulinum toxin injection with significant reduction in pain, improvement in posture, range of motion, and mobility. And this improvement was noticed at 2 weeks period, which is the maximum effect of botulinum toxin after injection. There were no serious complications encountered with all of them. They all tolerated the procedure significantly. And the 3 cases of developmental dysplasia of the hip, they needed only single round of injection to get the desired outcome. Though the CP patient, he was injected twice because of her original spasticity and of course the delayed presentation. She was 17 years. And the initial improvement was at 2 weeks after injection, but we injected her after 6 months, just after the weaning of the dose of the first botulinum toxin injection. And of course, the selection of the muscle was according to the clinical presentation. So as we all know that the options for treatment of stiffness will range between physiotherapy, under anesthesia manipulation, surgical debridement or releases, but the gain of range of motion with physiotherapy is often modest. And surgeon can do forcible to overcome adhesions and manipulation under general anesthesia, because he is going to exert to move the joint, but without fractioning, without producing any fracture to the already weakened, the long-standing and the bedridden. And sometimes in refractory cases, we go for surgical release of adhesions. It is a multidisciplinary team, and it includes a pediatric neurologist, the orthopedic surgeon, rehabilitation, and physical therapy. And we have a good experience with botulinum toxin in our center, and that's why we raised this as a management technique in these cases in the post-operative stage. It reduces the post-operative spasticity-related pain and in post-operative contracture as well. And it causes that the chemical denervation of botulinum toxin lead to temporary paralysis, which relieves the muscle overactivity. And this is a direct cause of muscle shortening and decrease of range of motion. We have to know that why the botulinum toxin has a weaning period of 6 months or maximum 7 months with intensive physiotherapy, and this is because of the sprouting that will occur after this case. So our cases helped that botulinum toxin reduced pain, increased the range of motion in cases of DDH, especially the post-op complicated cases, and the CP patient post-hip surgery. And this confirms the previous reports that was mentioned before, that botulinum toxin can be effective adjunct therapy in stabilizing the condition and improving quality of life in CP patients. It also helped faster recovery in post-operative cases. So it is a promising preliminary results that should be taken consideration of and followed up by a large scale studies, or, for example, in a multi-center basis. And it is a rewarding management option, well tolerated without side effects. It should be considered as a management plan in post-operative children, especially those who are refractory to the standard treatment. And also sometimes we get a referral from the physiotherapists that they're having difficulty in dealing with the patient due to the increased spasticity. And after giving the botulinum toxin in the selected muscles, their job is much easier. Muscle selection is very important. Sometimes we use it under ultrasound guidance, but most of the time without. And as we mentioned, it is a multidisciplinary approach. Subspecialties involved to reach the well-defined treatment goals and outcome. There are the three cardinal features: the pain, the spasticity, and the range of motion. We have to look for them in our clinical exam, set the real goal in order to achieve with the botulinum toxin injection. Usually we go inside the facial compartment for the good diffusion and the maximum effect. The appropriate dose is very important so that we will not maximize the spread or reaching a muscle that it is not the targeted one. Post-injection, which is very important, the patient should be enrolled in a comprehensive, extensive physiotherapy and rehabilitation. Sometimes we have to go for surgical technique even after botulinum toxin, or sometimes we used to do long-term casting. This will be patient dependent. And to our knowledge, no previous study has shown the result of botulinum toxin in pediatric stiff hips in children. And our limitation, the number of patients and lack of control group. So we raise the point that it should be given in selected muscles, and it is affecting in relieving pain, improving range of mobility in patients with DDH, complicated post-surgical, and CP. And it is a rewarding management, well tolerated without side effects. And muscle selection and participation of all concerned subspecialty will really improve the outcome. Thanks a lot.
Are there any questions?
And the pain. Hello. Your country is?
I am Egyptian, but I'm practicing in Saudi Arabia.
In Saudi Arabia. Is the botulinum toxin approved for this indication in your country?
Yeah, it is approved for treating spasticity in pediatrics. And
Okay.
it's FDA approved actually.
Okay, so you have already the indicated dose established.
Yeah.
And you use this dose. How did you select the dose?
Okay. So regarding the dosing issue, as you all know, that it was initially approved by the FDA that 2 to 3 international unit per kg per muscle. But according to our experience, that you can reach even higher than that. Usually we go doses that maximum you reach 20 up to 25 international unit per kg. And the maximum, even if the child is an international unit per setting. For having said that, you have also to select according to the muscle bulk. For example, the small muscles you can go with 20 to 30 international unit. For the big muscles like the quadriceps or the hamstring, you to 50 international unit. So to keep yourself just limited with the dosage, you will not get the benefit that you need. And it is a matter of experience. By time you can go up and monitor the effect. I have seen a lot of cases that been injected before 2-3 settings without much benefit. The right dose, they really show the effect.
And did you take into account to select the dose, I don't remember the abbreviation. There's a classification of for cerebral palsy, the GR. It's like functional. Yes, that's.
Motor function scale.
Did you take to see which was the dose?
That's right.
And sorry for so many
That's
questions.
fine.
I'm medical monitor for going in United States and Latin America, and that's why. Did you monitor the potential spread of the botulinum toxin? In other words, did you had any protocol to check with the parents how the childs were?
Yeah, the two important issues, as we mentioned in our slides, the first thing that the child should be enrolled in a comprehensive extensive physiotherapy program. And the other thing, we have bi-weekly visit to the clinic just to monitor for the effect or any side effect.
Maybe I missed it. How long was the follow-up?
Yeah, the follow-up was 2 years.
And did you say for the injection, you injected this muscle in echo sound?
Yeah, sometimes we use ultrasound, but most of the time we just use it directly without ultrasound guidance.
Electromyography, no?
No, I don't have experience with that.
Okay.
And also we have the experience in injecting Botox to the parotid gland for sialuria.
Have you know that specifically problems after after the injection, or in another question, if you when using ultrasound, you prefer an special of the muscle?
Yeah, usually you go with the that contains the neuromuscular bundle. This is the area that you should target in the muscle. And regarding the side effects, usually what you encounter just a very hyperparexia, just like a half degree, something like that. It's the same like, receiving a vaccination. Little pain at the site and little redness at the skin area. That's it, which will take 1 or 2 days and go up.
Okay. Thank you very much.
Thank you.
Okay, we will continue with the last presentation of Yubica Lilic with the presentation of qualitative analysis of the parenting styling.
Okay. I will be very short since I'm the last one here to present it. My paper is actually about children that went to congenital heart disease and had their operation in our hospital. And I was thinking maybe this presentation would be much more. It was yesterday when it was about pediatrics and cardiology, but it is also okay to present it today. We work in a small hospital in Macedonia, which was a former country from Yugoslavia. It's in the south of Europe. What is very interesting that although Macedonia is a very small country, our hospital works with high level of medicine support. Our director was actually he was educated in Germany, so the whole system that he learned there was transferred in Macedonia. That is another interesting thing, because Macedonian mentality is very slow and very passive, and in that atmosphere we have to rush with a German style of working, and we have much difficulties, but we are trying to spread around what we have learned. And plus, I'm living in Macedonia, but I was born in Germany, so that's somehow I'm in between, in the middle. So what our hospital is special cardiac surgery. We are 3 psychologists there, and things that we work is also with children that went to cardiac operation, and also with their families. I won't be bothering you with the numbers, but what is important, I will show this picture. So every year we make the operations that we have, and we collect the children that went to this surgery and a member of their family. We collect them, and with cooperation with the Red Cross, we make a summer camp. It's near in the Lake Ohrid, that is one of the most oldest lakes in Europe. And we have 5 days work in supporting these families. While we were working, actually the main point was to somehow support the families and of course work psychotherapeutically. Meanwhile, we will measuring 3 aspects. That is stress, with perceived stress questionnaire, cope, the strategies they use for coping with the stress they've been through, and parenting styles. We just wanted to parenting parents have. So during 7 years, we have collected about 80 parents and 80 children that went through this summer camp. This year, in June, we will have another group, 10 children and 10 parents. So the age is different. From 5 to 14, we can see the results. It was a simple statistics. Why I've put this picture? These are all children that went to this surgery. The result for them was completely positive, but what was happening with the parents? This is the statistics. A little bit further. I will say that the statistics here shows that mothers of children with this operation showed significantly higher score on concern when compared to mothers of healthy children, which is absolutely to be recognized, and I think it is also expected. Here is the statistic about the coping styles. From all different coping styles, 15 of them, some are actually problem focused, some are emotional focused, and some are described as dysfunctional coping styles. So on the dysfunctional coping styles this mother have, that is the denial, they show statistically significant more than the mothers who don't have children that went to this surgery. Denial means that they are actually ignoring everything that is happening and that they have a negative style that something bad happened, so they have a sharp border when they talk about this operation. According to the according to the parenting styles, most of the mothers show significantly they were authoritarian, which is also to be expected. Authoritarian parenting style means that these parents don't have much flexibility and supporting for their and they are not much supportive for the children. This doesn't mean that they don't love their children or that they don't care, but being in this complete state of fear, stress, catastrophic expectance, they've learned that only if they are very they show sharp borders, the child can be safe. What is interesting that the qualitative analysis difference in these parents when they apply this, they are behaving with their children. Although they have authoritarian parenting style, actually they behave to their like permissive parenting style. What means this? In the atmosphere, the parents laugh and show like a little bit that they're actually giving everything that the child can do. So they approve much of it, but that is not what they think. They act as if they are authoritarian and they speak as if they are permissive parenting style. The child, when it receives this, it receives verbal message that is dual, because he sees that the mother is strict, and from the other hand, in the atmosphere, she's behaving like she's approving everything. So the children receive double meaning messages, which absolutely creates a conflict. What is here interesting? Okay, in the another coping, yes. When these parents, it was very difficult to work with these parents because showing denial was not only while we made these questionnaires, but it was also heavy to work with them because they didn't want to talk what they went through. They didn't want to be informed what actually can happen to their child in future and to them as a family, as parents. So it was at the beginning of the camp and at the end of the camp, it was much more different. They changed during the camp. One of the main reasons why these parents are in denial, it is an assumption, but it makes sense, is that they are not informed and they are not educated what cardiac disease means. They mostly think that it's a terminal phase, but actually cardiac disease is not such a. But in the fear of asking and receiving an answer, they are choosing to live in not asking because of the fear of the answer they will get. So in the end of the camp, we finally tried to somehow shake the things, to talk, to educate them. Meanwhile, this camp, we have a pediatrician that comes and has lectures so that they can be informed correctly what with the child happens. About the perceived stress, concern, as I said, is actually very, it's something that is to be expected. Also, we made an autogen training. It's about a guided meditation for these parents. And during this psychotherapeutic work with the parents, it's very heavy. They also, interesting to see how they also developed a disease during this period while they suffered with their children. That's mostly psychosomatic things that happen to them. And one of the points, what we as psychologists work, which is very important for me to have structure when I'm meeting them and when we are trying to make a closure, is actually to bring close to these parents that what they have find firstly as a diagnosis and then went to the whole operating process and during the hospitalization and during the etc. Is at end, and to somehow psychologically bring close to them that the fear really go in fading out, that now it's a new process for their children. Normally we have also of the diagnosis, so we are not talking that every child has a good prognosis, but if it is so, then we bring it to the persons and to the parents and try to really that they get into sense that their child is good. Even if the child is good, these parents don't believe it and have fear, and that goes on and goes on. And this is the point where we somehow intervene. What is interesting in our hospital these days, I'm also hearing how the hospitals are working, and I don't know how it is in the world. I've searched a little bit about cardiopsychology, about psychological departments in cardiac hospitals. There are some, but it is not much. It is not very much applied. We work as a multidisciplinary team, and I think that the psychological team is the mediator between the doctor and the as I also yesterday made my comment, the doctors have a complete rational picture of what's happening. They're very precise, they are very intellectually supported, and they know how it will be, or 99% they know how the actual situation will be. From the other side, we have parents and children that are completely emotional, and because of this emotion, they cannot hear, they cannot perceive the facts. And here are we intervening because we know the realistic situation, and we know how overwhelming emotions can be. We try to translate what doctors are talking about, and trying to find time and energy and a space so to tell it to the parents in the right moment, so that they really perceive it as a important thing. Well, that's about it.
Okay, thank you. Are there any questions? Yeah?
Yeah, for how long was the camp?
The camp is 6 days in the past 7 years.
Okay, and you have a good attendance rate every year?
Yes, we have. We choose, I could say that in our hospital about 30-40 children during are operated, and we choose 10 of these patients, mostly with social economical status that cannot afford psychological interventions or cannot afford pediatric intervention. We choose the children and the parents that are mostly infected by the dysfunctional situation after the diagnosis and the operation.
Thank you.
Okay. Have you analyzed what's the mean socio-economical situation for those parents with these children, and have you followed them to how many years?
How many years do we follow them after the operation?
Yeah.
Well, the pediatrician who has made the operation has contact with them because they went to controls. We, as a psychological department, have contacts with the families. But I don't understand. Do we do a follow-up?
Yeah. Yeah.
We are in contact because
Okay.
that's not much. 10 families have on this camp. During the year we are also in contact. So there is also another thing, because it is a cooperation with the Red Cross from Skopje. In the families that are much burdened, we give also financial support and help them to make some discount on the controls. Help them in sending the children to, I don't know, to schools because they can't. So it is a combination of social and medical help for these children.
Yeah, I say that because many of those children seem to live after operation. So when you decide to stop the following for these families?
That is only when the pediatrician says, okay, this child is completely okay, he can go on with his life, but they're different diagnoses. It's not all black and white, and for those that need, we are there. It is absolute communication between our department and the pediatric that had made this operation.
Oh, it's more. I think like getting these chronic or severe ill children back into normal life is really a challenge. It doesn't matter which sickness it if it's cardiac or cancer or anything. And what we really need is a long-term follow-up for these families. We do certain camps like this for our patients with bone marrow transplantation and cancer. We do skiing camps and things like this. So this, I think, we need to get more into those and into the follow-up, so we can actually see how our medical procedures affect these families.
We're open as a department. I can stand for that we're completely open for the families. They have absolute direct contact with us, because once you work psychotherapeutically with a client, then you cannot make a distance. Actually, we're very close, and many times we were there for them, but that is a somehow isolated example. It should be much more accepted from the national policy, and that's what we do, but hopefully we will do it.
Okay. Thank you very much for your presentation. And I would end this morning with complimenting you for being here so long, and the organization to be here with us and to invite us. Thank you very much.
Lunch is supposed to be at 1:35, and we're really early. And the bar is not open yet. I look at the German girl. The girl from Hamburg. Thank you so much. Oh, it's another something. What happened is, see, this is a program that runs everything that's coming in from up here and from the computer. From the camera, it goes in here, and it goes in here, and we decide whatever goes live. Okay. Like right now,